Well, it's an issue we decided to start looking at, and it has to do with depression and mental health on the continent. Yesterday on VSA, we decided to explore all of this and how we have been able to put a finger on what exactly is wrong with some of us. The thing here is that once upon a time, there are no experts on the continent, but today we have people who are trying to make us understand that people are not bewitched, people are not sick, but people definitely need help, irrespective of who they are. So mental health and well-being is our focus on VSA. Welcome, I'm Sulaiman. People are faced with a host of challenges, some of which never leave their consciousness. They struggle to cope with the memories of those events and end up with the disorders of trauma. These triggers depression, in extreme cases, suicide, as sometimes known or unknown. Poor diagnosis and reportage of these problems have led a society where many people deal with mental health challenges alone. Africans also go through mental disorders like PTSD, that is a post-traumatic stress disorder, where the memory of a past traumatic event leads them to a very bad state. Some of these events range from an accident to incidents that fail to go. It is sometimes an attack on individuals, communities, and the witnessing of an event that may not be directly linked or happening to the persons who suffers from PTSD or depression. And again, that is why on television sometimes we have to put a caveat on some of the things we show, just in case that just might trigger something that may never go away in your mind. Well, joining me to unpack depression, PTSD and suicide today, Dr. Frank Njenga, he's the head of Mental Health Task Force in East Africa, Kenya, and Bright Shitemi, founder, Mental 360, an NGO that deals with mental health issues. Gentlemen, you're welcome on Village Square, Africa.
Thank you.
Thank you.
Well, Dr. Frank, the issue we've been looking at, I'm excited we're looking at it. Once upon a time, the continent just wouldn't want to look at it. People would think that some of the things anyone is going through, perhaps you have to look towards the family or the religious homes. Can one have a mental health condition and not be aware of it, to start with?
In fact, that is precisely the problem with mental disorders, that in many of them, not in all of them, in many of them, the person who is the sufferer of that particular illness does not actually suffer from it in the sense that he is not aware that the illness even exists in themselves. Meaning that if you tell some people that in your view as a doctor or as a friend or a neighbor, that you believe that his behavior or his conduct in general is a result possibly of a mental illness of one sort or another, the likelihood is that that person will say, no, I mean, I feel fine, don't you see, I look very well, no. But there are other types of mental illnesses in which the person who has the illness will actually tell you, I feel exceedingly sad, I feel unhappy, I feel lethargic, I am not able to sleep. So there are those two extremes. One, where the person will deny or will not acknowledge the illness, and on the other hand, the person will experience a great deal of pain from the illness itself.
Okay, we'll come back to you. Let me bring in Bright Shitemi here. Bright, you have been working with a lot of people who are dealing with mental health challenges, in your country. Tell us some of those, you have met. How did you even, because listening to Dr. Frank, he says sometimes one might not even know that he or she needs help. So how do you get to know that these people need help?
We work very much, especially with the youth, through raising awareness of mental health. And for us, it's a big problem, as Dr. Frank Njenga said, that many people are not aware that they're actually going through these challenges. And for us, it's using the power of storytelling, people who've already gone through these challenges, who come out and speak on the things that they went through, helping others to now see them on social media or see them wherever and say, oh, that person is going through A, B, C, D. I'm also going through the same, so I need to reach out. So we're looking at the power of storytelling, the power of music, the power of art. Many young people are interacting with music, poetry, going into events or watching things on YouTube. So using this channel where we are meeting them where they are and talking to them about mental health issues and how to identify and where to get help. And that's how we've been doing it so far.
So, Dr. Njenga, back to you. We need to first, establish some of the triggers of, mental disorders. Sometimes we understand some are biological, some are psychosocial. But again, we need to start understanding, what can actually trigger some of these things in us humans, especially Africans.
I think let's talk about human beings first, and then we'll talk about Africans. I think in general, there are a number of things that are well recognized as probable precipitants or things that are associated with mental illnesses in general. The first and perhaps least obvious is the fact that, like all biological characteristics, your intelligence, your height, the color of your skin, and that sort of thing, mental disorders tend to run in families, just like diabetes or hypertension also tend to run in families. So if you've got a family history of a mental illness, just like when you have a family history of diabetes, the chances are that you will have a higher probability of getting that illness than the general population. Secondly, experiences of trauma, very important, particularly childhood trauma that one may go through. Adversity in a social setting. Adversity here means that people who have difficulties, say in relationships, intimate relationships, challenges of that nature. Then, of course, there are other things. So you mentioned PTSD, post-traumatic stress disorder, a very common cause of traumatic events, particularly in people who have been recently exposed to one form of trauma or another. Exposure to drugs, alcohol, and cannabis and other drugs. So, in a nutshell, there's a whole myriad, and very sadly, some of these factors act together in making the situation worse. For example, you could have somebody who was recently bereaved, a close family friend has died, and then they compound that by taking cannabis or alcohol. So all these things sometimes work together to make your situation more difficult.
I'll come back to you, Dr. Njenga. Let me come to Shitemi here. Some of the things, looking at some of the footages, we saw earlier, what comes to mind is the care, and the manner with which some of those who have such mental, challenges have been handled, in Africa. Some are put in chains, some are believed to be bewitched or some kind of voodoo. How do you manage to navigate all of this when you are dealing with some family members, to letting them know that, hey, this is something that needs experts like Dr. Njenga?
Yeah, again, that's been a huge problem, especially now in the context of the African society, where mental health issues are viewed as either, they're usually connected to evil spirits or, something else apart from what it actually is. And it's been a challenge because some of these people who are doing this are actually educated people. You'll even have doctors who are maybe not psychiatrists who are still propagating the social stigma towards mental health. People who are sitting in high office who will not allow their own children to access mental health services because of the stigma. So for us, number one is to attack the stigma, and that is by raising awareness, letting people know that this is what it is, and this is how. Yes, you can do it. Yes, you can go to a religious leader, but you actually need medical attention, and making them know that look, it is a disease like any other, and in most cases, maybe you will need medication for some time. Maybe you won't, but just the first step of going to towards talking to a professional is going to help you get out of that situation. But I must admit, it's a huge problem. It's something that will take a long time to fight, but you're more than prepared to do that.
Well, we'll come back to know how you're handling that. Dr. Njenga, let's stretch some of those things you've highlighted, talking about, genetics. And it is very key here that people understand, what you have just painted. So, for instance, if a friend or relative is mentally ill, how does one handle it just before a professional like you comes in?
Oh, excellent question, because the reality all over the world, but in Africa in particular, the role of family in the management of mental disorders in general is crucial and critical, because, as you said perhaps at the introduction, the number of mental health experts in relation to the population on our continent is very bad. There's a time some years back when I did a paper on the number of psychiatrists in the continent of Africa under the title of The African Psychiatrist, 1 in a million, meaning that for every 1 million people on the continent, there is one psychiatrist. So really, much as we'd like to pretend that we're very good and very efficient and very able, in particular psychiatrists and other mental health workers are very, very, very few indeed. So what we like to promote from where we sit is the reality that family and the community are literally the first port of call in the event of any mental illness, and empowering of families and communities, including the spiritual leaders in our society, is really key in the early stages of the identification and management of illness. It's not possible anywhere in Africa, to my knowledge, to expect that mental health experts will be able to manage the very large numbers of mental illnesses that we have.
So in other words, the family unit is very important here. And we've also seen cases, Africans are highly religious people. We have seen cases where some of these people who need expert care are taken to religious homes. How do you deal with that when such cases come before you, knowing full well that perhaps maybe you have a patient you haven't seen has suddenly been taken away from the hospital to a religious home?
When I was a medical student many years ago, we were taught, as it turns out completely wrongly, that spirituality had nothing to do with health and in particular mental illness. It now turns out that mental health experts have arrived at the consensus that spirituality is central to the healing process in those people who are spiritual. Now, what we teach now is that we do not impose on our patients any particular type of spiritual life. Indeed, any particular spirituality, either this or the other one. But we encourage those who are spiritual and those who are people of faith to hold on to their faith and to exercise their faith to the extent possible. And now, in specific answer to your question, if somebody comes to me and I make a diagnosis of depression or schizophrenia, whatever it is, and they tell me that they would like their priest or their imam to come and pray for them, my position is as clear as daylight. Yes, you must, because your imam is important to you, your priest is important to you. But even as you go to get your spiritual healing from wherever it is that is given to you, also take these tablets, which I have suggested that you take. In other words, we work completely together with faith-based organizations.
This is quite soothing and revealing, knowing full well that this psychologically and even spiritually can help when people are allowed to bring in their faith just as they get treatment. Bright, I bring you back again. You know, this has to do with the community. Africans live a communal life, and you have also painted a picture of, stigmatization, and this is where I want you to speak to. How do you, continue in your advocacy so that, because your job will be, or rather, Dr. Njenga's job will be easier if you succeed in your advocacy, speaking to the people, letting them know that truly this is something that needs attention of experts, that these people are not bewitched after all.
Yeah, sure. And for us, it's to look on the best models and towards passing this message. I think we need to invest more in or what we call human-centered design programs for mental health, where people in different communities and different contexts are engaged in providing solutions which are tailor-made to their own to their situation. Like Dr. Njenga just said, you're people who you can't separate religion or spirituality from their journey towards good mental health. So working towards having more human-centered design programs, and also having, secondly, a multi-sectoral approach towards prevention. Can we have workplace policies? Can we have safe spaces in schools and policies in schools? Can we involve all players in this conversation, religious leaders, even the spiritual leaders in the community? Can we involve them in these conversation? And lastly, more awareness creation will lead to increase and improve in access to care. So again, mental health starts with the community. The stigma and even the triggers, they start and end with each one of us. So you should not be the reason for someone failing to seek help. So that's the message we are trying to pass to everyone, that look, stigma and even the trigger for some people starts and ends with you. So you are the key towards unlocking this problem and towards people reaching out for more support.
I think the good news here today is what both of you have highlighted, especially Dr. Njenga letting us in on the collaborative effort of experts like himself and a faith-based organization in the healing process of anyone who's been attended to. When we return, I'd like us to speak more on, depression, suicidal ideation, and some other mental health problems, and how we can get to identify them in our environment. Stay with us. Welcome back to VSA here. Today we're still looking at mental health matters, and we have our guest in Kenya, Professor Frank Njenga, who is the head of Mental Health Task Force in Kenya, and of course Bright Shitemi, who is the founder, Mental 360, an NGO that deals with mental health issues. Gentlemen, good to know you're still very much there. I establish this for us, Dr. Njenga, and it has to do with some of the things we deal with on a daily basis. For instance, depression. We understand that some of us are depressed without knowing that we are depressed. perhaps take us through some of this so that people can get to understand what they're going through, or if you can actually, make it in a very simple language for better understanding. How can someone, know that he or she is depressed?
Wow, that's a lot of questions you've asked in one breath, but that's okay. That's the nature of life. The first question whose answer you seek is how can one be depressed and not know it? That question is, I think, premised on the presumption that if, say, you have toothache, you would be the first one to know that you have a toothache. If you have stomachache, you're the first one to know that you have. You don't need your mother to tell you that you have a stomachache. Depression is different, substantially different, for a number of reasons. The first one is that in the initial stages, it very gently and very insidiously creeps up on you. And you sometimes just start off by feeling slightly off color, feeling a little bit weak and lethargic, and perhaps on a number of days you don't sleep too well, and that's kind of like it. The point that I'm making here is an important one, because depression and anxiety, the two conditions that are very, very common in many people, are what we call spectrum disorders. Spectrum meaning that you move from a normal state through very mild and then moderate to severe depressive state to very severe depression. Meaning, as the condition creeps in on you, sometimes you're not aware that it has reached the definition that a doctor would recognize as a formal illness. So, unlike a toothache, which is categorical, either you have toothache or you don't have toothache, anxiety and depression exists on a spectrum. The second question that you are asking is to do with how common is depression, and indeed how common are mental illnesses in general in the community. Across Africa, if you were to go to a market in your city, or if we were to go to a marketplace and asked 100 people about their mental status, our estimations is that 10 to 11% of just normal people in the streets who have not taken time off to go and see any doctor will in fact have conspicuous or diagnosable mental health needs, which will not mostly be recognized. In other words, as of this evening, 10 to 11% of our viewers have diagnosable mental conditions. But not all of them need to see the doctor. Not all of those conditions are severe. So that's one of the facts. The other fact that perhaps you might want to put to bed at this time is a reality that all of us, at one point or another, about 20% of us, at one point or another in our lives, will go through a depressive illness, whether it's diagnosed and treated by a doctor, whether it is recognized by yourself as such. The reality globally is that 1/5 in a family of 5 people, we say that one person, either the father, the mother, or one of the 3 siblings, will. So the point that I'm making is that depression creeps in on you, number one, and secondly, it's a very, very common condition that is not always recognizable by the untrained eye or ear.
I'll come back to you, Bright. Let me just take this, stretch this with Dr. Njenga. And it is something I've always heard, growing up, and I want to pick you on that. I've heard that as a human being, you have your 5 minutes of, mental instability on a daily basis. I don't know how true that is. Perhaps you want to better situate that for us. So we're not all, 100% normal on a daily basis. Is that correct?
That's lazy. That's lazy. It's lazy because it fails to recognize that a diagnosis of a mental disorder has to occur in the context of a formal diagnosis in accordance with internationally accepted classification systems. And if you are not making the diagnosis within the accepted classification disorder, what you're engaging in is inaccurate. I was going to use a stronger word, but I will rest it and say it's inaccurate. So diagnosis is a formal classification diagnosis made in accordance with internationally accepted classification systems, and anything outside of that is foreign and alien to me as a doctor.
I'm happy you said you're trying not to use some stronger words. Let me bring in Bright here, because some of those things, Bright, I'm sure you encounter will be people using such strong words to describe or define people who are going through some form of challenges. So Bright, when you go to communities, have you seen how tell us how some communities you have visited, care for these people before experts like Dr. Njenga come in?
Yeah, good question. I think for us, for most communities, most people do not understand actually what people who are going through with mental health conditions need, or how to even address it. And so the point number one we want to do is educate them. And it starts with the language. For example, you hear people say, Bright is bipolar, but we're saying we need to separate Bright from the condition. We can say Bright has bipolar or Bright has depression, but not say Bright is depressive. So starting with the language, that's the key point where the stigma starts. And also you see, again, people who are going through these conditions, like you mentioned earlier, being secluded, not being allowed to make decisions, which is quite unfortunate, because most of people who are going through mental health challenges actually can deal with the normal day-to-day challenges if they get the necessary support. And then you have cases where that people forget that their role is just to support the person, not necessarily to diagnose or to cast aspersions. Like Dr. Njenga said, you need to actually go to a qualified professional to know that for sure this person has this or that condition. Also, we've been struggling again for us to find words for some of these things. And in Kenya, you'd hear people call someone wazimu or mwenda wazimu, which means psycho, crazy. You'd have, I'm sure now in Nigeria, you have your own words. So we're trying to educate people to use appropriate words that are not condescending or stigmatizing towards people with mental health conditions. And also there's the issue of blame, where people are blamed for conditions that is beyond their control. Some are born with them, some encounter them through the process of life. And just educating people to understand that anyone can actually get through these or get to that point at any point in your life. So there's no reason to be judgmental of someone who's going through mental health conditions. So these are some of the things we are working on. And also the last thing is about suicide, where people, suicide is criminalized. And for us, we say that someone who's going through these challenges, who is suicidal, needs more support than being branded as a criminal. Because if you give them that necessary support, then they do not get to that point. And so that's my long and short answer to that.
Let me bring in Dr. Njenga here. Dr. Njenga, we've heard cases of where people, suffer some physical, pains. At the end of the day, going through the process of, diagnosis, which you've highlighted, it turns out that those were actually indicative of some mental, disorder in that person. Tell us pretty much more on that.
In a technical sense, somatization. In other words, soma is the body, and people are staged to suffer from psychosomatic disorders, meaning that they have psychological conditions which manifest as body aches and pains. In fact, an interesting, perhaps, point that we would say here is in the English expression that would say something like, so and so is being a pain in my neck, just pointing up there. What that really means is that so and so, your wife or your sister, is causing you so much stress that the muscles of the back of your neck are so tense that you experience that stress from your mother or from your husband or from your whatever as being stressed. So a lot of people actually who are depressed in Africa present to their doctors and to health centers and other health facilities complaining of headaches or complaining of backache or complaining of what in East Africa they call malaria kubwa, the big malaria, which is the feeling like they are kind of feverish. While in fact, closer evaluation and examination really determines that the primary reason for that person presenting themselves to the medical facility is the fact that they have a hitherto undiagnosed depressive illness. So yes, the somatization or mental illnesses presenting as pains and aches all over the body is a very important condition. And part of the other reality that makes it very important is that when you as an African goes to the primary healthcare person and he doesn't know about what is called somatization, then they start doing all sorts of tests. They do blood tests, urine tests, stool tests, x-rays, MRIs, and all these very expensive tests, trying to look for diseases that really they will not find because they're really backing up the wrong tree. And in our programs of educating primary healthcare workers, we lay a lot of emphasis on the need for them to recognize the fact of the commonness of mental disorders, and secondly, how easy it is to recognize them, and thirdly, how effective treatment is, even at the primary healthcare level.
So, Bright, now stigmatization again comes to play here, and how much of the condescending words we have used to describe, some of our relatives and friends who are going through such, challenges. Tell us, by way of, re-educating some of us, how we can better treat these people, so that people can know that it just might be me, it might be you, anyone can go through what this person is actually going through at the moment. There's no need for anyone to stigmatize this person.
Yeah, sure. Number one is for the society itself to educate itself, because mental health issues are actually more common than people believe. I mean, if you talk about mental health, most people will think about the man walking naked on the streets, but it's affecting at least 1 in 4 people. That's in the world population. And in Kenya, again, those are the numbers. So it's 1 in 4 people. And like it was mentioned earlier, most people are actually going through, I think the numbers were at 40% of people who go to hospitals on a regular basis actually show symptoms of mental health conditions. And so it is from this understanding that it is very common that society needs to appreciate that, look, it's only, we hold the key to unlocking this problem. And so, again, apart from teaching mental health language, is to show people that, look, it is not, because there's very strong ties to, like I mentioned earlier, evil spirits. There's strong ties. People will tend to blame something and then look for solutions where none are. People will go to doctors to get prescriptions that are non-existent. People will go to witch doctors to get certain help that will never be found there. People will go to even pastors in church to try to sort out depression or issues that are beyond the scope of that individual. Yes, that individual can be part of the process of healing, but that individual cannot hold all the answers to your journey for healing. So these are the sorts of messages you're passing around to people, that we need to be more aware, and that mental health actually is taking care of your mental health is a day-to-day endeavor. That it is not just about you caring for others, but also starting to care for yourself, because self-care starts with you. If you don't take care of yourself, then you end up going down the path of bad mental health, and which can lead to illness. And so more importantly, it's also now appreciating, understanding that how you need to treat other people, because we are the triggers for some of these conditions. It is trauma. It is that parent who is violent towards the children that is passing down this trauma across generations. It is that man who takes advantage of a woman, for example. It is your acts that actually lead to some of these challenges. So having this information is really key to unlocking the problem.
So, Dr. Njenga, are all mental illnesses curable, or are there some just we might have to live with till we die?
Excellent question. In fact, one could ask, are all illnesses, leave out the mental illness question, just are all illnesses curable? Or are there some that you live with until you die? Of course. I mean, malaria is really very, very easy to treat. Pneumonia is very, very easy to treat. But stage 4 cancer of any condition, you live with until you soon die. Mental illnesses are kind of similar. There are those that, if presented to the doctor early, can be cured completely. And there are those that when they come to the attention of the doctor late in their presentation or occurrence, getting them to be treated will take a little longer, and perhaps some of them, sadly, people have to live with them until they died. Now that you ask about death and mental illness, did you know, for example, that some mental illnesses, like say schizophrenia, reduces your life expectancy by up to 20 years, meaning that if you have schizophrenia and your brother doesn't, and if you're born at about the same time, the person with schizophrenia on average will live 20 years shorter, meaning that mental illnesses are serious illnesses that actually do very often. And that's not just by suicide. It's not that people who have mental illnesses kill themselves. No, it's not that. It's other conditions. People who have mental illnesses are more likely to suffer from physical conditions like diabetes, like hypertension, like strokes, even some cancers, than people who don't have those mental illnesses. So really, strategies for early recognition and treatment of people with mental health needs go far beyond the imperative of making people mentally healthy. Yeah. They also go beyond. And in fact, now that I think about it, mental illnesses and heart diseases are almost like hand in glove. By that I mean, if you have a mental illness, you are more likely to have, say, heart attack or coronary artery disease, heart attacks. Conversely, if you have heart attack or coronary artery disease, you're more likely to develop depression. So depression and heart diseases in particular is a two-way street where one often leads to the other. Bottom line, look after your physical health and you have a good chance of having good mental health. And the converse is also true. Look after your mental health and you're likely to live longer.
Well, quite frankly, listening to you now means that, one is as important as the other. But there's something you also mentioned, which I want you to speak to, which is suicide. How is it that, once people have that tendency, sometimes the moment we thought that it has left that individual, we end up losing that same individual through that same, suicide. How can society truly help anyone who's attempted suicide not to go through that route again?
Now, just two quick ones. The first one is that people don't, in our language anyway, commit suicide. People commit crimes, people commit adultery, people commit bad things. People die by suicide, meaning that a person who does a suicidal act should not be viewed as you view a person who has committed a crime. You view him or her as somebody who has a mental illness, almost in all cases, who requires the care and attention of his family and the medical profession. Meaning that the language, and we've heard something about language, the language about which we talk about acts of suicide and attempted suicide discriminates and stigmatizes merely by categorizing attempts of suicide together with criminal or moral offenses. That said, three things I'd like to say about suicide. The first one is that every 800,000 people, it is estimated, every year die by suicide, more than the number of people who die in conflict situations. Every 40 seconds, it is estimated, one person somewhere in the world dies by suicide. So really, the act of suicide is more common and more lethal in its ways than people recognize. One of the most effective, there are a number of effective ways of preventing suicide. One of them are systems and programs for the early recognition and treatment of depression. So if you want to prevent suicide in your society or in your community, put in place systems of recognizing people who are depressed early on. Secondly, and this again is well recognized, remove from circulation lethal instruments. Lethal instruments means pesticides, easy access to pesticides, guns. A lot of people kill themselves using guns. So really a systematic look at a community level of the ways that members of that community kill themselves would be very helpful indeed in reducing the number of people who eventually end up killing themselves. And then, of course, programs of education, such as we are going through this evening, can also be very helpful indeed in passing on that message.
I'll tell you how important this has been for everyone watching today across the continent, more so for me, because as we go into, closing, looking at stigmatization and pretty much what the society or governments can do. Thank you, Dr. Njenga, because you have raised or you just painted a good picture. I've also just learned something. People die by suicide and not commit suicide, because using such terms or words would amount to also, stigmatization or trying to label them as criminals. Now, Bright, take us through this before we close with Dr. Njenga. Stigmatization is still a big problem, you know, in dealing with mental health across the continent. You know, for instance, previous abusers of drugs, ex-convicts, refugees, people who have undergone psychotherapy, they're still stigmatized in the public and in most African societies. Tell us some of those things in closing from you, Bright, that we should do, you know, as Africans to help those who have gone through, you know, such life processes, to get them back to be reintegrated and seen as just one of us.
Yeah, thank you for that. And I think I'd love to tackle that question by just speaking to the media directly. Now, the media is a very powerful tool, and in Africa, you've seen there's a lot of penetration for TVs, for radio. So people are actually learning very much from these media channels. And so through these media channels, you'll see very graphic representation of people with mental health, or very negative stereotypes being propagated about them. And so we actually need to, I think there needs to be a program to educate the media on how to report on mental health issues. We need to show people with mental health conditions in roles that promote their dignity and respect. You know, providing a nuanced perspective in stories involving persons with mental conditions, rather than reinforcing negative stereotypes about these individuals. So if that is done at that high level, then it will cascade down to the people who are listening, and they're going to affect that even more in a better way. The second thing is now speaking to government, that we need to put in place systems that support people with mental health conditions. One of the key reasons why, for example, with mental health, even users, what are called substance users, would go back to abusing, for example, is because they really have no programs, or they really have no support. They go back to the same environments. They go back to the same hopelessness and joblessness. So as government, what can we do to then support people who are going through these challenges? What programs can we put in place? Second is about the professionals working hand in hand. There's a broken system where you'd find psychiatrists work on separate line, nurses will work on a separate line, psychotherapists will work on a separate line. So can you find a more concerted effort, or a more
where they can all, you know, work in concert?
Yes.
Yes. Let me bring in Dr. Njenga so that we can close in. Thank you, Bright. Dr. Njenga, listening to you, I think both of you have actually, been able to educate the continent, and it is something that I feel that we should, stay on. But quickly, there is a dearth, of experts like yourself taking care of mental issues. How can the continent, grow more experts like yourself? Because in every society, from what we have gathered, we know that, the physical being and the mental being are one and the same. Dr. Njenga, did you get my question?
No. Sorry, I had zoomed out almost literally. Just say the question again, please.
Okay, we're closing with you now. We just want to find out how we can have more experts like you, to help the continent and even the world, because we know that there are not too many of your kind at the moment.
Well, I think this kind of forum is very healthy and very, very helpful. If it doesn't pass any other message, it helps pass the message that mental disorders are common. Number two, that early detection and treatment leads to excellent outcomes. And really, nobody can, in Africa or anywhere else, can have the kind of impact that is desired in the containment of mental disorders on their own. I think Bright has said, we need the media needs us, the government needs us, we need the government, we need mental health advocates, we need the community, we need the people who have lived experiences. But just speaking from myself and speaking about a country that I know well, our country, Kenya, I actually see a lot of light at the end of the tunnel. And I believe it's not a train coming to hit us. I believe it is the light of dawn, a new dawn in our understanding and appreciation of the commonness and treatability of mental disorders. And I have to say, because I have contact with colleagues in Nigeria, in South Africa, in Egypt, Ethiopia, and everywhere else, that really dawn, a new dawn is coming to Africa, and that the dark cloud that has hung over us over the years is really breaking away, and that the message regarding mental health in our continent is getting its own fair share of airtime, literally airtime.
It's a fine place to say many thanks to you both, Dr. Frank Njenga and Shitemi, Bright Shitemi. Many thanks for speaking with us. I know it's pretty much ninth time in Nairobi, Kenya at the moment. You both have been such a nice company. Many thanks.
Thank you and good evening. Bye-bye.
Thank you.
Well, bye-bye. So Africans deal with a variety of challenges that drain the mind. From financial difficulties to war, there are a lot on the plate of an average African, yet wellness is key. So check within, see within, and if you feel any less of yourself, it may just be time to see a professional. Let's all be well. Many thanks for being nice company, and remember, you can watch us live on the go at newscentral.africa, and of course start times at channel 274. I'm Sulaiman. I'll see you again tomorrow.